Okay, welcome everyone who's watching this live and to those who are watching this as a recorded webinar. I'm Dr. Jason Jones, and this is Let's Talk About Sex Therapy, Common Problems and Solutions. So this is the second time that I am doing this particular workshop, which is intended to be a beginner to intermediate level of introducing sex therapy concepts to couples counselors, other therapists or psychologists who deal with individuals or other matters of sexual health with their population. So this being the second year, we have listened to some of the feedback from the past year, and that is why this year this is going to be a little bit more of a lecture format. Last year, we did a bit more of an experiential process in terms of integrating these concepts through discussion, but that was not exactly what the participants wanted at that time, a little bit more lecture component. They wanted to learn a little bit more, not have their cameras on, and be able to kind of absorb the material. So that's what we're doing today. And I am very interested in any of your feedback as well about this presentation and the content, or even the process in which it is delivered, because it's important to be able to keep improving this presentation year to year. New research needs to be updated in, some concepts are added or not taken away just yet, but concepts continue to be added to this kind of presentation. So my hope is that with a presentation, a workshop like this, that it will help to expose people who are interested in using sexual health principles, sex therapy concepts into the therapy or counseling, psychology practice that they are performing for clients. So from my perspective, I also know when I was training to be a certified sex therapist with ASECT, how difficult it was at that time to get access to all of the material that was needed for a competent sexual health training up in Edmonton, Canada, where I am. It wasn't easy. And I know how many local therapists want to talk about sexual health matters, or their clients are needing to talk about their sexuality. And so I'm hoping that events like this can help increase the amount of scientific knowledge and evidence-based treatment around sex therapy that is in everybody's community, wherever you're coming from today. So Angela is the co-host today, and she will send out a copy of the PDF of this presentation as well. There's other material that you would have received too so far, and if you have any issues, please make sure to contact Angela during this workshop. So before we go any further, I do want to acknowledge that I am presenting on Treaty 6 territory here in Edmonton, Alberta, a traditional meeting grounds, gathering place, and traveling route to the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We acknowledge all the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So if you don't know me well at this point, I'm a registered psychologist in Edmonton, Alberta, Canada. I have been a registered psychologist for 10 years. In 2014, I became an ASECT certified sex therapist under the supervision of Dr. Corey Harushka, who's also in Edmonton. And then in 2019, I obtained ASECT certification to be a sex therapist supervisor. So I have 8 supervisees right now that are learning sex therapy under a supervision process through ASECT with me right now. And so I founded, and I'm the director at Loving Choices Psychology, which is a private practice in Edmonton. And we have 4 three psychologists and one counseling therapist right now. Two of us are certified sex therapists. And Angela Corey is our sexual health educator. She is currently at the Institute of Sexual Education and Enlightenment, doing her schooling for her certification as a sex educator. She's a registered nurse by trade. So in terms of the objectives, so we have 6 objectives that we want to get through today. And those 6 objectives are coming from the ASEC standards of what those objectives are related to. So we have 2 different areas of objectives. The first one is core knowledge area I, which in ASEC is the range of sexual functioning and behavior from optimal to problematic, including but not limited to common issues such as desire discrepancy, lack of desire, difficulty achieving or maintaining arousal, sexual pain, penetration problems, and difficulty with orgasm. So that's the core knowledge area. And so specifically from this workshop, you should be able to meet these 3 objectives, where you'd be able to describe the differences between Masters and Johnson's model from 1966 and Besson's 2000 model of the range of sexual functioning and behavior. By the end of this training, participants will also be able to describe how closeness and separateness constructs from Esther Perel relate to the range of sexual functioning and behavior. And by the end of this training, participants will be able to describe at least 3 adaptations that can be made to increase understanding of sex-related functioning and behavior in diverse communities. The second area of objectives is from Sex Therapy Training A under the ASEC guidelines. And this is the theory and methods of sex-related psychotherapy, including several different models. So for today, we want to be able to learn at least 3 models, 3 different methods, and 3 different theoretical concepts that can all be used in sex-related psychotherapy. As we go through today, I'll be using the terms female and male, but I do want to point out that those are those are old terms that don't always meet the needs of what we're trying to describe. So I do want to just note that if I'm saying female, it's assigned female at birth, and male would be assigned male at birth. That's a language clarification that I want to make sure that we're all on the same page about. Language is very important, especially when it comes to sexual health matters. So there may be other areas where I'm using terms that might be unfamiliar or might even feel offensive at first. I will be using the word fat to describe what the medical community calls obesity. And I'll go into a little bit more details on why we're choosing to use some of those words, including fat, a little bit later. So during this day, these are basically the 3 different parts of the workshop. We're going to go through what the common problems are that we typically see in sex therapy. There's 20 or 21 common problems that we're going to go through. Then we're going to go into sex therapy concepts. So I have 10 concepts that I'm going to present today and discuss. And then finally in the afternoon, we are going to apply those concepts into some common problems and actually work through that. So how we're doing that is we're going to have 4 different client profiles. And we'll be working with those client profiles throughout the day. And those are hopefully a good representation of some of the client profiles that you might see when you're doing your work with clients. So problems, concepts, solutions, that's how we're going to move through the day. So let's begin with some of the common problems. So I want to distinguish two different models around the problems. So the first model is the medical model. So the medical model is typically what we would use for DSM diagnoses. So we would try to apply the measures of disorder or dysfunction through the medical model. And through the medical model, there are a number of common problems that are from the DSM that impact the sexual lives of our clients. So let's go through these are female specific ones in the DSM-5 at first. So female sexual interest and arousal disorder. So they combined desire and arousal for females in the DSM-5 into one disorder. The genitopelvic pain or penetration disorder is another one for females, and female orgasmic disorder. So what's important about the medical model is the criteria that they have in order to discern whether or not there's a dysfunction or disorder. And that criteria is also really based on whether the individual who's experiencing the issue is experiencing it as distressful to them. So they have to have marked distress because of what the issue might be with their sexual health. Now that is very interesting because we'll talk in a little bit about how that actually really changes the nature of the presenting problems, whether or not it meets a certain threshold of diagnosis versus it might be subclinical, but just as distressing for the client, or perhaps even more distressing to the client. So when we think about female DSM diagnoses, one of the more common ones that we do deal with is pelvic pain. So I just want to give a little bit of, there's a couple testimonials here on pelvic pain, just to understand a little bit more of what women are going through when they're experiencing these pelvic pain complaints.
Oh my gosh, I think I have had pelvic pain probably close to 10 years. It's affected almost every area of my life, but most importantly, probably my intimacy. So yeah, it's been rough. It's been rough.
So I have suffered from pelvic pain probably for over like 5 to 6 years now. And it definitely impacted my sexual life, along with just day-to-day sitting for too long, standing for too long. All of that was an issue. And of course, urinate, like going to the bathroom and getting the urine all out at once was just a challenge every time.
So those are the female sexual disorders that are in the DSM-5, and we move into the male sexual disorders. So erectile disorder, so those that can be issues in getting an erection or maintaining an erection. Male hypoactive sexual desire disorder. So that is different than the female diagnoses, where this one is just about desire. They don't combine it for men the way that they do for women for arousal and desire. So male hypoactive sexual desire disorder. So not having as much interest or desire for sexuality as one may expect, which is fairly ambiguous and might cause distress, has to cause distress in the individual as well for diagnosis. And then premature ejaculation and delayed ejaculation. So both of those around the orgasm for the male. And there was a study in the Journal of Sex Research in 2016 What they found, they were trying to look at some of the prevalence rates with the new DSM-5 diagnoses that changed things a bit in 2013. So they found that using this criteria, 38% of men had a sexual health disorder diagnosis, and 22.8% of females had a sexual health disorder. Now, those numbers were surprising for them because traditionally, female sexual dysfunction or disorder has been measured higher than men's. But what they found was that only over a third of the men and women who were reporting a problem with their sexual functioning, only a third of them ever actually sought help. So that's very significant, that for both of these issues with men and women around sexuality, there's an extremely big gap between those who are impacted by it and those who are actually seeking help. And so I would also say, in my clinical experience, that females are generally much more likely to seek help. I see a lot more females around sexual health than males, and perhaps because of a larger issue around men not feeling comfortable asking for help, or how that might impact their sense of self a little bit differently. And we'll get to some of the cultural reasons behind that in terms of patriarchy right away. Some of the other common problems that would fit within the medical model is substance or medication-induced sexual disorders. So that can be SSRIs are very commonly prescribed for anxiety or depression. And a lot of SSRIs have sexual side effects. So if your client is being treated with an SSRI, there could be an impact that has on their sexual system. Also, any kind of medical treatment that has impacted the genital areas before, that can impact nerve endings and sensitivity, or even blood flow. So those are important to consider. The paraphilic disorders. So these are the disorders that there's been a lot of debate about how to really kind of handle paraphilias, or how to not pathologize kinky or fetishistic behavior that really doesn't cause any problems, isn't hurting anybody. There's no personal distress that's being experienced. So paraphilias have been difficult in the literature and in the research for them to really get a good handle on, because as soon as you talk about someone deviating from whatever the heteronormative conditions of sex that people think should happen are, then you get into moral debates about whether or not it's okay to do some of these things even with consent. So the 8 conditions that are a part of paraphilic disorders in the DSM are exhibitionistic disorder, fetishistic disorder. So fetishistic disorder is recurrent or an intense sexual arousal from an inanimate object, or a very specific focus on a non-genital body part that then causes significant distress or functional impairment for that individual. So you can see how difficult that can be to diagnose, especially if what is causing the significant distress in the individual is their perception of culture's non-acceptance of that behavior. And that could really be what's fueling some of the distress in it. So does that, what do we do in treating that? We would need to talk about moral incongruity, sexual health values. We need to talk a lot about cultural impacts, and what these individuals have learned about sexuality, or how to accept or judge themselves. So mentioned exhibitionistic disorder, fetishistic disorder, frauderistic disorder, which is rubbing up against another person with or without their consent. Pedophilic disorder, so attraction to minors that causes significant distress. So again, attraction to minors could cause significant distress for some individuals and not others, and that would obviously change the course of treatment. Sexual masochism disorder, sexual sadism disorder, and then transvestic disorder is still in the DSM-5. And that is around wearing clothes that are associated with a different gender that also causes distress. So again, you can see how the distress might really be because society does not accept certain behaviors. And so that's where the distress could come from. And therefore you have to talk about where is this distress coming from? Moral incongruity within oneself that's been internalized, or from external factors. The last two here, the other specified sexual disorder. So that's used when a client doesn't meet full criteria for one of the sexual health disorders, but they will also specify why they don't meet the disorder. In unspecified sexual dysfunction or sexual disorders, they don't meet the criteria, but the clinician is not making a statement as to why the criteria are not met. So that's what makes it unspecified. Most of the time in Canada, we don't deal with those issues, but folks down in the States might have to be aware of that from time to time.